そう、いろんな人入ると思うんですよね。自分は入らないかな。私は入らない方がいいかなと思うんですよ。うん、先生はプレゼンテーションあるから。うんうん
点灯しているときが入りますので。
ভাইয়া ওই যে ফেসবুকে একটা ওই কনফারেন্সটা জয়েন করার জন্য লিংক দিছে
Hello, welcome to everybody. Welcome to our session today, Portable Health Clinic in Asia Pacific Advanced Network, APAN53. I would like to invite all of you to this session. It's a great pleasure for us to have all our PhD researchers in one platform after a long 1 year. We know that we all are passing through a pandemic for more than 2 years now. However, we are very much thankful to all our partners for continuing your PHC activities in spite of this critical situation. Today, the title of our session is Current Experiences and the Possibility of Portable Health Clinic for Telehealthcare Service in Rural Communities in Asia. I am Rafiqul Islam Maruf is with you today as the organizer of this session. I'm working as an associate professor in Medical Information Center of Kyushu University Hospital. And we are very pleased to have Professor Naoki Nakashima with us today as the session chair. Professor Nakashima is the director of the Medical Information Center of Kyushu University Hospital, Japan. Portable health clinic services are being delivered as primary and secondary level of care to the rural communities of various Asian countries, including Bangladesh, China, India, Indonesia, Malaysia, and Pakistan for last few years. Besides this PHC system is considered as a very useful tool to be used in the post-disastrous areas in many countries, including Japan. This session will cover all these things. Today, this session has two parts. In the first part, we will see the presentation from 4 presenters on the current operational activities in Bangladesh, Indonesia, Japan, and Malaysia. Each presenter will speak for 12 minutes. In the second part, we will have an open discussion for 30 minutes, including our all partners from other countries. You all are welcome to raise any queries you have during this discussion session and discuss the obstacles and challenges for searching the way out. Now, before we go for the presentation, I would like to invite Dr. Ashir Ahmed for his opening remarks. Dr. Ashir is an associate professor, Faculty of Information Science and Electrical Engineering of Kyushu University, and he is one of the pioneers of the PHC system research and development. So please welcome Dr. Ashir. Dr. Ashir Ahmed.
Thank you, Dr. Maruf, for the introduction. I will make a very brief welcome speech for everyone. First of all, thank you very much for joining this session. This session is very important to us for many reasons. When we developed Portable Health Clinic, we remember we wanted to be useful to the rural areas, people in the rural areas who do not have quite essential, do not have access to essential healthcare service in an affordable manner. So we tried to become useful to them. And then I'm so happy to see that the PHC family is growing bigger in different dimensions. We can see the expansion of PHC in different geographical areas, as Professor Dr. Maruf also mentioned, that from Bangladesh, it went to India, Thailand. We have pilot in Pakistan, Malaysia, Indonesia, and many family members are joining from other countries as well. And we are expanding to not only in Asia, in African countries as well. So every time we visit a new country, we find something new challenges. So this is a great opportunity that we can gather your experience as a very nice title today, that the experience from different country we can gather during this session today. So I'd like to welcome you all to this session, and we will discuss, we will list the challenges. Maybe we can find one challenge in one country, This may not be the case to another country as well. The biggest challenge, the common challenge that we find, how to collect the data, how to preserve the data, and how to share the data. So sharing the data has a lot of challenges. Some standards are being done in European communities. So we are also looking at how to store the data in a standard format, how we can share the data in a standard way as well. And there are cultural challenges, there are business challenges, there are technological challenges. So through this particular session, we'd like to gather and we would like to hear the experience that you got from your country or from your activities. So I'll welcome you all to listen to the speakers from different dimensions. Thank you very much.
Thank you very much, Dr. Ashir. Now we will go to our presentation session. As I mentioned, we have 4 presenters. I would request all presenters to keep your speech within 12 minutes. So first, I would like to invite Dr. Kimio Kikuchi. Dr. Kimio Kikuchi will make her presentation on her MCH activities in Bangladesh. Dr. Kimio Kikuchi.
Thank you for having me. Okay, so today I'm going to introduce a maternal and child health module of portable health clinic. And I also introduce some challenges during the COVID-19 pandemic. So at first, I'd like to talk some about the background of this maternal and child health module. So in general, continuum of care in maternal and child health is essential to improve their health status. However, in Bangladesh, only 18% of mothers and children receive the continuum of care. So one of the main reasons of this low rate is a distance to a health facility. So in that context, the portable health clinic is one of the solutions to improve the continuum of care. So at first, I'd like to talk some about the back. However, the COVID-19 pandemic posed severe challenges to providing portable health clinic services. So this is the outline of our maternal and child health module. So our implementation site is in 2 zones in Chittagong Union in Shariatpur district, Bangladesh. And the study period is from June 2019 to May 2022. And we are following up women and children from 16 gestational weeks to 6 weeks after delivery and birth. So these are the pictures of our activities. Here is a picture of health workers, our health workers. And these are the picture of health workers checking health status of mothers. And these are the pictures of when they are while they are measuring the weight and the height of baby. And this is a picture of mother talking with doctor in Dhaka through video system. So these pictures are before the COVID-19 pandemic. So in that period, our activity was very smoothly conducted without any problems. So, but as you know, in March 2020, like other countries in the world, 19 spread all over the country in Bangladesh. So as you can see here in these pictures, the lockdown strategy was issued in a country, and then this is a picture of our study site, Chittagong town, and there are no people on the street, and the stores are shut down, and then only the car of promotion of COVID-19 is on the street. So in that context, our activity faced difficulty to providing the care. So in March, a lockdown was issued, and then we couldn't visit mother's home. So we couldn't provide any service during this period. And then in June, the lockdown was over, but we still couldn't visit mother's home because people are afraid of getting infected with virus. So we decided to shift to a phone call based health checkup. So a phone call based checkup is a checkup based on the interview. So we selected only the top items that could be interviewed by phone, like 10 questions for mothers and 8 questions for children, like fetus movement and vaginal bleeding or child's diarrhea. And if mother have any problem, mother or children have any problem, doctor call mother and then directly talk to mother and their problem. And before starting to this phone call based telehealth checkup, we developed a guide for health workers on how to advise pregnant women to prevent infection or how to take care, like cough etiquette and what to do when having a fever. These are the picture of health worker calling mothers by phone and then asking whether they have any problem. Sometimes sales worker gave some instruction on cough etiquette to the village people. And then after this period, from October 2020, we slowly started home visit telehealth checkup. But this time the situation is completely different from this before pandemic. So we developed a kind of guide for health workers for home visit. So we developed this kind of guide and then we conducted a training for trainer. She's a trainer and then by video, internet video. And these are the picture of, she's a trainer and trained trainer. She gave training to a local health worker. And then she's showing how to wear mask and sanitize hand properly. And these are the pictures of health workers. She is one of our health workers. And we asked her to check every day and record every day her body temperature. And then every time she go to mother's home, she call mother beforehand and then ask if they have asked to check their temperature. And if she has any fever, so that time she postponed the appointment of home visit. So to getting avoid infection. So these are the pictures of health workers sanitizing mother's hand and then checking body temperature. And then while checking health status of mother and the children, they are protecting themselves using gloves and a mask. So we conducted home visits during this period. But last year in July, again, there was a lockdown because of the increase of the cases. So we again started phone call based health checkup. But by this time, health workers were already used to how to do phone call based health checkups. So we could smoothly shifted to a phone call based health checkup. And then in September, the lockdown was over. So a home visit telehealth check began again. So recently we conducted a questionnaire survey to women in Chayagon Union. And according to this result, there were a huge problem of mental health. Around 38% of women said that they felt depressed feeling during the COVID-19 period. And they also said that around 19% of women said they had inaccessibility to health care services. So this kind of health problem was very critical in this period. I think it is not only this area, but also other area of Bangladesh was in same situation. So in addition to that, we observed some issues and challenges. So through our phone call-based health checkups, we found that some women didn't answer properly whether they had any cold or feverish symptoms. So it might be because of the social stigma related to COVID-19, but it sometimes made it difficult to understand whether their mothers had get infected with virus or not. And we also found some challenges in phone call-based health checkup to detect health problems in mothers and infants without apparent symptoms, because it is interview-based health checkup. So we can't deny that some health problems we might be overlooked some health problems during this period. And then also we observed there were a lack of medical personnel and shortage of medical supplies for maternal and child health. One of our participant mothers said they visited a health facility because her baby had a health problem. And when she arrived at the hospital, there was nobody because it was lockdown period. And as soon after arrived there, her baby died. So such kind of very miserable situation happened, maybe not only here, but also other areas too. And despite of these challenges, we found some strengths of our portable health clinic. For example, although a phone call-based telehealth check detected only a part of health problems, it acted as almost the only means of getting doctor consultation under lockdown period. And also through the questionnaire, we found many women felt mental health problems. So we included such kind of mental health questionnaire and the portable health clinic, phone call-based portable health clinic. And we detected one woman who had a depressive symptom after after delivery. So I think it is really important to include such kind of interview-based questionnaire for mental health in the portable health clinic. And also, we think that we prepared the guide and the training in advance before the problem happened. So this kind of preparedness was really helpful for our research to avoid a contingency situation. Thank you very much.
Thank you very much, Dr. Kikuchi. And this is wonderful to see that how you could change your service pattern during the COVID situation. And this is really a critical situation for everybody, but you could continue your services during this period. So I think there is many things we can learn from your service procedure, service policy. And I understand that many people may have many questions. So we have a discussion session. I believe that those who have your question, please keep it and we will discuss during the discussion session. So thank you, Professor Kikuchi, once again. So now I would like to invite our second speaker today. Our second speaker will be Dr. Anai Akane. She is from Kyushu University Institute for Asian and Oceanian Studies, QAOS, and she will make her presentation on our PhD activities in Indonesia. So let's welcome Dr. Akane for her presentation. Dr. Akane.
Thank you very much, Dr. Marufu. Good afternoon and good morning. My name is Akane Anai. I'm in the Kyushu University Institute for Asian and Oceanian Studies. The title of my presentation is Factors Associated with Mental Disorders During COVID-19 in Central Java, Indonesia. So here is the outline of my presentation. First, I would like to share some background information, and secondly, research objectives, method, result, summary, and study limitation and strengths. So first, this graph shows global prevalence of mental disorders before the COVID-19 pandemic and during the pandemic. Upper part of graph A shows the global prevalence of major depressive disorders by females and males. And the bottom part of graph B shows prevalence of anxiety disorders for both females and males. And this blue part shows prevalence before the pandemic, and the orange part shows prevalence during the pandemic. So as you can see, the prevalence of these mental disorders were increased during the pandemic compared to the before the pandemic in both females and males and almost in all age groups. So this is say mental disorder is one of the big health issue in the COVID-19 pandemic. And also WHO state this issue as the major public health concern. So this slide shows the contributing factors of mental disorder. As you may already know, factors such as stress, genetics, nutrition, perinatal infections, and environmental hazards are associated to mental disorder. However, behavioral factors associated with mental disorder during this COVID-19 pandemic is still largely unknown. So therefore, there is need for more empirical research. So the objective of this study is to identify behavioral factors associated with mental disorder during COVID-19. So there are the specific behaviors recommended by WHO during COVID-19, and we used these variables for the analysis: wearing a mask, keeping social distance, washing hands, not shaking hands, physical activity, and healthy diet. We analyzed if these specific behaviors during this COVID-19 pandemic could be an associated factor of mental disorder. The study site of this study are Kulon Progo, Sleman, and Klaten in Indonesia. These three districts are located to Yogyakarta in Indonesia. The study was designed as a cross-sectional surveys, including questionnaires, health checkups, telemedicine, which is online doctor's consultation. Data were collected every month from February to April from the same participants repeatedly. However, for this research, only baseline data collected in February were used. And in total, 214 people participated in this study. Participants were community residents in these three districts and voluntarily recruited. So this graph shows the daily new confirmed COVID-19 cases in Indonesia. The baseline data were collected at the peak of the first wave in February 2021. In this study, self-reported questionnaire SRQ20 was used to evaluate the mental disorders of participants. It is developed by WHO and consisted of 20 questions. People who responded as no in all 20 questions were classified as no symptoms of mental disorders. And the people who responded yes, more than one questions were classified as some symptoms of mental disorders in this study. So this figure shows the whole process of portable health clinic research activity conducted by local health center staff with an assistant from Gajah Mada University. For this analysis, data collected from questionnaire, which shown in step number 2 in this figure, and also health checkup, which shown in step number 3 were used. This slide showed the conceptual framework of data analysis of our study. The outcome of this study is mental disorder. Which is evaluated by SRQ-20. And explanatory variables are these. And these are explained in the previous slide as specific behaviors during COVID-19, such as wearing a mask, keeping the social distance. So to identify if these specific behaviors during COVID-19 are associated to mental disorder, multivariate logistic regression was conducted by using SPSS, and we include these variables: age, gender, marital status, body mass index, status of hypertension, status of type 2 diabetes as confounding and control variables. So this is the result of the analysis. So significant association was found in social distance, shaking hands, physical activity, and healthy diet. So participants who are not always keep social distance were 4 times more likely to have mental disorders compared to those who responded that they always keep social distance. And participants who are not always shaking hands were 68% decrease in odds to have mental disorders compared to those who responded that they always shake hands, shake hand when greeting with people. And the people who responded not trying to improve their physical activity or will try later were 6 times more likely to have mental disorder compared to those who responded that they were already trying to improve their physical activity levels. And participants who responded not trying to improve their healthy diets or will try later were 4 times more likely to have mental disorders compared to those who responded that they were already trying to improve their diet to be more healthy. So in short, people who does not have ideal behavior during COVID-19 pandemic, which are not keeping social distance, having physical contact like shaking hands with others, not having physical activity, and not having healthy diet, are indicated as predictors of mental health, mental disorder in COVID-19 pandemic situation. So I would like to summarize today's presentation. First of all, as background, increasing mental disorder during COVID-19 is concerned. However, behavioral factors associated with mental disorder during this COVID-19 pandemic situation is still largely unknown. Therefore, we conducted data analysis to identify if specific behaviors during COVID-19 associate with mental disorder during COVID-19. So we examined these 6 behaviors in this study, and 4 of them are indicated as predictor of mental disorder. Which are people who are not always keep social distance, people who are always shaking hands, people who are not having physical activity and healthy diet. So our study result may be useful as basic data for preventing mental disorders during COVID-19 pandemic, and also for the health support for patients suffered mental disorder in this COVID-19 pandemic. So as next step, we need to verify our study comparing previous studies and need to deepen the discussion. So our study have some limitations and strengths. First of all, possible selection bias such that our study samples are unlikely to be representative of residents in Indonesia. And second, a cross-sectional survey that does not permit conclusion to be drawn regarding causal links between independent and dependent variables. And the third, small sample size unable to do subpopulation analysis by sex and age groups. The strength of this study is data include biological, behavioral, and socioeconomic factors, which allows adjustment by biological factors. So this work has been funded by Kyushu University Data Science Program and the Telecommunication Advancement Foundation. And we would like to thank the University of Gajah Mada and health center staff in Indonesia who provide support for the fieldwork. So this is all for my presentation. Thank you very much.
Thank you very much. Thank you very much, Dr. Akane. And this is a nice study. Actually, we know that depression and mental disorder is a very important topics for discussion during the COVID situation. And you have focused on that using the PEC system. So I think this is very important study, and this opens a new window for the PEC system as a whole. So I'm sure we will have some question. We will discuss it during the question answer session in the discussion session. Thank you very much. Then now I would like to invite our third speaker today. And our third speaker will be Professor Naoki Nakashima. And Professor Nakashima, as I mentioned earlier, he's the director of Medical Information Center of Kyushu University Hospital. And today he will make his presentation to show how PEC can work. In Japan and around the other countries. So I would like to welcome Dr. Nakashima for his presentation. Dr. Nakashima.
Thank you, Maro. Thank you. First of all, thank you very much for the providing me to present this PHC, this post-disaster module. My name is Naoki Nakashima in Kyushu University Hospital. As you know, this is the ordinary PHC workflow for the non-communicable disease. You know, this in the rural area, this health worker provide health checkup by this PHC package, and right after she input all data, this system automatically makes the risk stratification into 4 color: green, yellow, orange, red, and only orange and red color we provide telemedicine from doctor call center in urban areas. This is B logic established by the international clinical guideline. So we use this B logic to make risk stratification in this NCD module. This is a disaster. You know, today is just a Memorial Day in Japan. Just 11 years ago, we had a really big earthquake, which hit the northeast area in Japan and evoked a tsunami, which killed over than 20,000 people in Japan. So, and after that, we have a lot of disaster in Japan and also in any place of Asian countries. And also we know after this big disaster, the NCD patients get worse because of the big stress. So we think this post-disaster management module is in need. we have another motivation. Japan has now super aging society, which will have very few medical resources in future, especially in rural side. Maybe 20, 30 years later, there is no clinic, no doctors in the village side in Japan. Therefore, we want to prepare PHC in Japan also. However, we don't have the needs in Japan right now. Only the needs is in post-disaster situation. That is why we want to promote this PHC post-disaster module. This is comparison between the ordinary situation and post-disaster situation. In the PHC module for NCDs, there's no checkup items for trauma, infection, etc. And there are many refugees in post-disaster shelters and also COVID-19. We found a big change of shelter after COVID-19. This picture is before the COVID-19 in Kumamoto earthquake area, the gym, in 2016. This is in same prefecture post-disaster. So we are very surprised to see that. So maybe this is a family unit to avoid infection, right? So I think it is very easy to install this kind of PHC digital system because we can put ID in this family unit. And this is the purpose and method of this study. So we have to establish the new logic we call D logic, disaster logic, to manage health in disaster refugees. One is variation from B logic to D logic to manage many refugees by the population management way. And the second is we have to cover the health risk like trauma, infection, etc., which are often occurred in post-disaster circumstance. So we developed three logic. So we have to combine these three logic to manage this post-disaster situation. This is the logic grouping algorithm by asking only three questions to use time efficiently. Only age, symptoms, and visiting a doctor. So if the subject answers 50 years old and no visit clinic, but symptom, yes. So he gonna have the D logic 2 symptom based. It takes only 3 to 5 minutes. But in the case, for example, 68 years old, yes, and regular visit clinic, yes, and she can have the D logic 1 full and D logic 2 full, so full program. It takes 30 to 40 minutes. This is B logic. I think we have to change this several items because, under the big stress, maybe blood pressure, urine test, skin lesion, and body temperature are likely to be worsened. So this is D logic. But this is not still working. This is just preparing phase. So we just establish this kind of the logic. Okay. And this is simulation data by the result of the health checkup in the ordinary time in Bangladesh of the 60 years or elder people, or about 1,300 people. This left hand is B logic results. So 60 years old or elder people shows the 70% of the orange and red result. Okay? But by this D logic, it reduced almost half, because in big stress, maybe this can get bigger to 40% or 50%, but it still works, I think. But in the case of this B logic, maybe it get over than 70, 80, 90%. It's really difficult to manage that. So this is D logic 2A, very complicated. But this is symptom based. Yes, this is symptom. This is loss of consciousness or depression, feedback, fever, like that. And this is the check sheet number linked to D logic 2B and D logic 1. For example, if the subject complain the depression, okay, so this is 2367. So 23667 is sleep disturbance and flashback, and general fatigue and loss of appetite, okay, and almost also 102. Okay, this is the logic 1. This is the loss of body weight. We can use body scale, weight scale by this the logical. This is all the results of the sensor devices. So we have this 5 pattern by the first grouping algorithm, but we can calculate the score by this D logic 1 plus D logic 2. The final score for this calculation, we can provide the telemedicine. Also, we check the PHC function vulnerability in the disaster situation. We have a lot of damage, of course, in the victims, but also in the relief workers and PHC, and also church. That means the electronic power and mobile network and mobile base station and generator and cables, right, in the local area by the disaster. So now, today, I want to focus on this PHC and charge, electronic power. So we have a lot of devices in the package, I mean the box, and this is the power, electronic power. But we have the device with a variety of the power system. And this is waterproof. There's no waterproof in these devices. So we have to think about this kind of the battery, and also the kind of the battery size also, because we have to have the backup. This is kind of the battery, right? So we have to standardize this kind of the battery. But we have the main merit to use this PHC from the the very peaceful time. Yeah. Okay. Because just switch the post-disaster mode. In this ordinary time, this work staff can use this system easily. So now she can use this post-disaster mode also. I mean, the maintenance is really important in this kind of the disaster system. Also, we will have the many collaboration with other researchers. We will have the meeting with Dr. Soshino in Kumamoto Red Cross Hospital at the end of this March. So he has this kind of drone system to bring the a kind of the very heavy device and food and also the medicine. So sometimes the victims need indispensable medicine like insulin, steroid, etc. So if we can find that kind of the victims in this shelter, this drone can bring that. So now just we start this kind of the collaboration. So these are results, but before we use this PHC post-disaster module in real disaster situation, we need to further research by rehearsal and practice training in real shelters. Thank you very much. This is all of my presentation.
Thank you very much, Professor Nakashima. And actually, this is another dimension of PAC. And we know that natural disaster is a common phenomenon these days, especially for the global warming, carbon dioxide emission, and this kind of things are increasing. And it doesn't care which economy you are. It can happen anywhere, any place, anytime. So I think PAC has a good opportunity, good scope of work in future in this direction. So this is very interesting for the development of PAC. So thank you very much, Dr. Nakashima. And then we have our final presenter. Our final presenter today will be Dr. Rishini Ilegovan. She is from Malaysia, University of Malaysia, Sabah. So she will talk on her activities, the PAC activities in Malaysia. So let's welcome Dr. Rish. Dr. Rish, it's your turn.
Thank you very much, organizers, for the opportunity and time given. Good day, everyone. My name is Rishini Alonggowan, can call me Rish for short, a medical officer from Hospital University Malaysia Sabah. I will be presenting on the portable health clinic service that has been run in Sabah, Malaysia. So just a brief introduction before we continue. The whole idea of PHC in Sabah started when these three outstanding gentlemen paid us a visit back in February 2020. So through series of discussions during that time, our team decided to bring the PHC service into Sabah, Malaysia. So why is this digital healthcare system important in Malaysia, especially in the rural areas? One of it is the difficulties to obtain healthcare services being unable or inaccessible by the rural folks, shortage of doctors and healthcare staff, especially in the rural areas. And also we are focusing on low income and low education group as well. Okay. So by having PAC on board, our team decided to conduct a research on the rural community in Sabah. We obtained our ethics approval on the 8th of May, 2020. The title of our research is the impact study of portable health clinic for rural communities of Sabah, Malaysia, a pilot study based in our objective is to improve the Kudat community people's health awareness, knowledge, behavior, and also their health status. This will be a cohort study for conducted over a period of 5 years with at least a yearly follow-up. Our targeted sample size is 500 people. So Sabah is basically the second largest state in Malaysia, which lies on the northern extreme of Borneo. There are 5 divisions with 26 districts. Our research will be focusing on the Kudat division, which consists of Kudat, Pitas, and Kota Maru, the 3 districts. Why we chose Kudat with a total population of 192,457? The 3 districts of the Kudat division has been labeled one of the poorest districts in Sabah. By collaborating with Kyushu University and Grameen Communication, we are using Gram Health system to capture the data for PHC system. We also had a visual online training back in August 2020 in order to further understand and use the system in the rural center. This was our initial proposed research period and timeline. But however, due to the pandemic that hit us, we have postponed all our activities till July 2021. And our first visit to Kudat was in October 2021, which was last year. Just to share with everyone, besides Kudat, we have actually extended our PHC service to other divisions of Sabah, which mainly all the other 26 districts as well. So I'm just going to show our program plan layout. Before we start off with a program, what we normally do is we'll need to select our village. We have to discuss with the district officer. We'll do a recce of the site and we'll have our team arrangement. Selection of village here, basically we will go into villages that has difficult access to health facilities, limited access for review with medical officers, or if there are any villages that actually requested for a health screening program. Discussion with district officer here, because we are going into different districts, each district will have their own district officer, each village will have their own village head or representative. So in order to carry out a program, we have to request permission through written black and white letter in order to proceed with this program. Recce of site, normally we'll do a survey of the area before going into the area because we'll be bringing in a team. So we need to know how is the situation in that area, how is the road condition like, and we need to arrange the appropriate transportation that is needed. Team arrangement, basically the team are from our hospital itself, from the university. Each team member will undergo a COVID swab test at least 2 days prior to program, and only asymptomatic volunteers are allowed to join so that we will reduce the spread of the current COVID situation. Okay. We are lucky in a way because each village that we visited will actually have a community hall or schools that we can actually use to give our services. So we do not have difficulties to open up tents or things in the village. So I'm going to show the list of villages we have visited. So over the period of 7 months, we have covered 8 villages so far. These 8 villages are basically from 3 divisions. We have covered the whole of Kudat division, West Coast, we have covered Kota Belud and Tuaran. We have covered Labuan as well, which is a federal state. And we have covered Tawau division, which is Tawau. So this was the very first village that we visited after we have postponed our whole PAC program till July 2021. Basically, the nearest village that we have actually went into is about a 3 hours drive into the interiors with road conditions of loose rocks, gravel road, muddy areas. The furthest we have traveled to is Tawau, which was about an 8 to 10 hours drive all the way from the university. We have also traveled to Labuan. Labuan, we have to use sea transport, so we have to transport everyone by ferry in order to get to the village that is in Labuan. A brief statistic from our overall program. Due to the pandemic situation, based on all the 8 villages that we have visited, we have screened about 463 individuals. Out of 463 individuals, 8.6% are considered healthy. The remaining are those with comorbids or any abnormal screening result that we detected during the health screening program. A brief screening finding, most of them actually have hypercholesterolemia, followed by hyperuricemia, high blood pressure, and hyperglycemia. Normally, the results of the screening finding depends on the location of the village. So if the village is by the seaside, normally hyperuricemia and hypercholesterolemia would be higher in our findings compared to the other 2. Challenges that we face during our PHC programs are, first thing is our urine dipstick screening. We noticed that during the program, a lot of villages, they are not keen to carry out this urine dipstick screening due to hygiene purposes. So discussed with Kyushu University in one of our meetings, we actually set up a booth beside the toilet and prepared clean water, clean soap, which actually improved the number of people agreeing to have their urine screened. Number of people attending, this is basically due to the COVID situation. So in order to increase the number of people attending to our program, what we do is we will normally swap the entire team that is going into the village to ensure that everyone is COVID-free, and we will actually inform the villagers beforehand that we have already swapped the team, everyone is clear of COVID, so that no one will actually have the fear of contracting COVID from us who are coming from outside of the village. Internet service. Internet service is an issue here because normally in the rural areas, it's very difficult to get proper line services. Sometimes you have to go, probably walk about 1 to 2 kilometers or go on top of some hills in order to get a proper connection line. So currently what we are trying to do, we have discussed with Grameen Communication and Kyushu University to actually come up with an offline system that we can actually use in the interiors, which would be helpful in future as well. This is regarding the PAC services that we have conducted in Sabah. Thank you very much, everyone.
Thank you very much, Dr. Rish. Wonderful, wonderful. And thank you very much, especially to your team to travel such places. I'm sure it was a hectic travel for all of you. It's a big team and very critical locations. But it's wonderful that people of that area could get some support from your team through the PAC services. And this is also interesting to know about the urine issues, because this is something comes from the cultural background. In different location, different country, maybe we'll see different kind of problem as one you detected in your area about urine. So I think this is very helpful for other culture also. We can know of each other through these activities. And we can learn from each other how we can overcome this kind of limitations, this kind of obstacle. So with this, I would like to conclude this presentation session here. And I would like to thanks all our 4 presenters once again for your wonderful presentation. Thank you very much for this presentation part. Now, I would like to move to our discussion part. And I believe besides our speakers, we have some other participants from Bangladesh, from China. We have colleagues from China, we have colleagues from India, we have colleagues from Indonesia, Malaysia, and Thailand, Pakistan also. So I would like to invite all of you to this discussion session. And I would like to pass my control to Professor Naoki Nakashima to be the chair of this discussion session. So please, first, you can raise, if anybody has any question to any of the speakers, you can raise your questions. And based on that response, we can continue our discussion. So I would like to pass to Dr. Nakashima.
Okay, thank you, Mao. So first, I want to invite any question to the presenters. So do you have any questions to the first presenter, Kimio Kikuchi, Professor Kimio Kikuchi, and also the next presenter, Professor Anai Akane, and then me, and then Professor Lishani in Malaysia.
If you have a question, please raise your hand so that we can recognize you.
In the chat. Oh, Rajiv. So please ask her to close the mute.
Yeah, you have this opportunity to speak directly. You can raise your question. Now you
okay, thank you very much, Nakashima Sensei, Dr. Maruf. First of all, I would like to thank all the presenters for your wonderful presentations. And particularly, I would like to mention about Nakashima Sensei's presentations. I firmly believe that is going to be a unique feature if we can transform the PHC into for the applicable for a disastrous situation. And to some extent, I know about the activities of Malaysia, how PHC is going on. And I know about, as I am living in Bangladesh, I know about the maternal and child health care, which has been conducting through PHC in Bangladesh. So I have, which is very new to me, about the mental health presentation, which presented by Dr. Akane. Hello, Dr. Akane. I have 2 questions. Basically, I have already written in the chat box. First question is, how did you choose the study participants? Was it random selection, or did you have any criteria to select?
金井先生、これいいかな。
じゃあお願いします。
Najib Sensei, I'm
Yes.
sorry. This field work were conducted by Gajah Mada University and local healthcare staff in Indonesia. So may I ask Professor Lutofang or Professor Nuhoris how a participant were recruited in the field?
Yeah. Thank you very much for the questions. Actually, the participant is a member of health program, which is specific for the chronic diseases in Indonesia. This is the national program run by the National Insurance Agency called Prolanis. And we actually recruited all of these members of the program. So it's not selected randomly, but by the list of the people that are enrolled on this specific program. So these all are member of the program that regularly do the medical checkup at the health facility. But due to the pandemic, there was a disruption. So then the PHC were piloted and implemented. Yeah, thank you. Hope this answers your questions.
Yeah. Okay. Thank you very much, Professor Lutfan. Yeah, I get it. Thank you very much. My next questions. Since the presentation is all about identify the mental depression or disorders, so in developing countries, human behavior is highly influenced by the flow of money. Actually, how much money I am earning. If the money flow, if I am not earning sufficient money for me or for my family, my mental situation, human mental situation is highly influenced. So that is what I meant. So how much money he or she has during COVID-19? As we know, income of many families had been reduced significantly or even stopped. So my question is, do you think reduction of regular income created mental disorders, or there were any other reasons behind the mental disorders or depression? Thank you.
Thank you very much for your question. Unfortunately, in this research, we didn't get the participants' social economic status, so we don't know how much they earn during COVID-19 situation. So, but this is one of the limitation, and I really agree the economic status will be very associated to their mental disorder, mental status. So in the, as I said, it's one of the limitation, but we have the data of the participants' occupation. And so in the future study, we will add the occupation as the variable, and we'll try to analyze again. So Professor Yokota, if you have any comment, please.
Yes, thank you. Yes, as Dr. Anai mentioned, it would be better if we could ask a question, how much change did you experience in terms of the financial before and after during the COVID-19? But unfortunately, that question was not asked. That's a next time we will include. Yeah. Dr. Lutofang, Professor Lutofang or Professor Nuhoris, any additional comment?
I think this is a very good questions that we haven't actually looked into details, but there will be, I think, very good idea to do it. But there has been also, we have to look into our data in detail, but I think some of the yeah, patients are actually already have a, let's say, quite well, good occupations. I mean, maybe if it's considered the persons that working in the informal sector, that would be one that really affected. But I think a significant persons that in our study is considered have fixed occupations, which is yeah, maybe not really affected. Although, of course, that maybe there are other issues also that then affect the total income. But in general, I think one which is considered working in the informal sector, which is, I think, roughly about 20% those who are affected in regard with the pandemic.
Yeah, yeah. Thank you very much, Professor Lutfon, for your explanation. Yeah, I understand. Thank you very, very much, Akane Sensei and Yokota Sensei. Yeah, thank you. I get it.
Thank you, Rajiv, for your questions. Any other questions? Any other questions and comments? So I want to invite some comments from each stations. So first, I want to invite Yandong Fu, Dr. Yandong Fu from China. Do you have any comments?
Yes, yeah, I'm here. Yes, Sensei.
Yeah. Do you have any comments or some suggestion to the presentation?
So far, I think all the speakers' presentation is wonderful. But so far, I have no comments. Thank you very much, Sensei.
Thank you.
Do you have any update of your activities? Can you share something from your side?
Actually, I do not prepare the slides. So I think maybe I can share some slides in our next online conference.
Okay, thanks. Next, I want to invite Dr. Manish Biani in Jaist, Japan, but he is originally from India, Jaipur. Dr. Biani, oh, okay. And then I want to invite Professor Helen in UMS Malaysia. Hello, Helen.
Hello. Thank you, Prof. Nauki. Yeah, nice to meet you all again. So as you can see, we have finally started our portable health clinic activities. And we are also in the process of getting from Grameen Communication the system for offline. Because in Sabah, there are many areas that there is no Wi-Fi or internet. And we find that the portable health clinic, the system is very good because we have all the data. And you can see immediately that many of our community are actually not well, you know. Only out of the 400 over, only a few percent, only 8-point-something% are healthy. So it's very good for us. And we also discover new diseases, like when we are doing the portable health clinic, and we found that very high uric acid level in those near the sea, you know. So it does make, I mean, it's easier with a portable health clinic. So we are very thankful that we managed to work together. And I think once the pandemic is over, once everything is back to normal, we will have more patients and we can see better results. So I think that's all. So I hope once the offline system is purchase it, then we will continue with the project. That's all. Otherwise, all the presentation is fantastic, and we learn a lot from the rest of the team, because we are a bit worried ours are not doing well. But when we see the other presentation, then we are comfortable that we are actually on the right track. Thank you, Prof.
Thank you, Helen. Today, I showed you the collaboration between our PHC post-disaster module and a drone, very strong drone system, the research. I think it is very useful. Drone is very useful for in the post-disaster situation. But when I visited your place, Kota Kinabalu, and I visited the area of the Kitabalu mountain area, I found a lot of village over the valley, big valley. Yeah, and the village has a lot of diabetes patients. So I think in ordinary time, I think this kind of the collaboration between PHC and drone system can work very well in that case. How do you think?
Yeah, I think so. I think the drone will definitely benefit us, because in Sabah, the road system are still very quite bad, you know. Yeah, so the drone will definitely be an additional add value to our portable health clinic system, PHC system.
Okay, thank you. I started this collaboration. I want to inform you that kind of the results of this collaboration research. Thank you.
Nakashima-sensei, actually, I have one question to you, actually. May I ask?
Okay, go ahead.
Okay. We have observed the potential transformation of PHC, especially for the post-disaster situation. May I ask what types of disaster you considered apart from earthquake or tsunami or COVID-19?
Thank you for your questions. Yeah, I think this kind of the earthquake and tsunami and flood and volcano explosion, like this kind of the nature disaster. And also, I think I agree, we can use this PHC for the pandemic of the like the COVID-19 or some kind of different pandemic also. So, I mean, we can use this PHC module in the ordinary time, peaceful time, and also this kind of the special time. By we just after we can change the module logic.
Yeah, I understand. Thank you very much. As you know that types of disaster, it varies from situation to, like volcanic explanation is different than a flood or flood caused tsunami or earthquake caused tsunami. So there might be some changes in the situation also. So obviously, I believe you have considered all the parameters or all the risk factors. Yeah. Thank you.
Okay, thank you.
Nakashima-sensei, may I ask a question?
Okay.
Ashiro-sensei.
No, thank you. Okay, it's just an extension of questions of question of Rajib. Sensei, do you see war as a disaster?
War as a disaster. War as a disaster.
Yeah, that kind of disaster, I think.
People like coming into a refugee camp or something. So,
but you know, the post-disaster situation, I think this is not for the acute phase. You know, acute phase is terrible, so it's really risky. And I mean, maybe after 3-4 days or 1 week after the disaster, right? So in that time, maybe many victims are staying the shelter and with very bad food, very bad circumstance, and maybe no medicine. I think we can support that situation. Maybe acute phase DMAT or some kind of the acute relief workers have to go there, right? And maybe wartime, it's always acute phase, right? So it's really difficult to use this kind of thing. So war is terrible.
I see. Thank you.
So, if Dr. Nicholas is there, I'm very interested to know about his reaction or his comment about because Dr. Nicholas is a professional in mental depression and this kind of thing. So Dr. Nicholas, are you there?
Hello, I am here.
Okay, if you are there, I'm very interested to know your feedback to the presentation of Dr. Akane. He was presenting his module for depression. Do you have any observation? How do you see it's different from your country?
I think in our country, for our mental health, we have a slightly smaller, our country is obviously smaller, so we probably have higher levels of psychiatric services, but they're all concentrated in large cities. So what we are planning to do to build up on what you've already done in your fantastic mental health research is we are going to research certain factors in our PhD program here in Sabah in Malaysia, which are suitable for an intervention. So instead of just looking at is there a mental health problem, is there no mental health problem, we're actually going to look at psychological mindedness, psychological flexibility, cognitive flexibility. So once we look at these factors, we will then be able to perform interventions in people that target these factors. So thanks for your presentation just now, because your presentation gives us hope that we will be able to conduct a similar study in our setting. And we have a large mental health team, so we will be able to deliver the interventions in the areas where we do the research, because it's very important to do research, but it's very important at the same time to do research that provides interventions after you do a screening.
Yeah, thank you very much. Thank you very much. I asked this question because I feel that there is a good opportunity for us to make a new module on PhD on mental health and depression, because you were working on that. Indonesian research is on that, where even Kikuchi Sensei is working with some sort of depression with the pregnant women. So there is a good opportunity. I see there is a good opportunity to form a depression module, to develop a depression module with all of your joint collaboration.
Yeah. So I would be very interested in collaborating. So later, maybe you can just send me an email from the mental health presentation. We actually have something called an ultra brief psychological intervention, which is actually 10-minute one-page interventions that can be done for depression, for anxiety, in any rural area. We have actually written them all in Bahasa Melayu, so obviously they can be used in Indonesia as well. And we'd be very, very happy to do a training course to share the interventions. We are actually doing a training course in early April. So if you all want, we are very happy to let some of you come along. It's being done online anyway. So then we can come along and we can get a training, and maybe we can build this module so that it can become the PhD interventional module for mental health. That would be nice.
Wonderful, wonderful, wonderful. Thank you very much.
Okay, thank you very much, Nicholas. And I want to invite the Professor Fights in Thailand.
Faiz bhai, are you there?
Fights? No.
Dr. Faiz Shah, are you there? Or somebody from Thailand side or Pakistan?
Hello, I'm here.
Yeah.
I'm from Thailand. So Dr. Fayaz is like, he cannot join today. I'm so sorry for him too. For me, I would like to be representative for Thailand. Thanks so much for all presenter and speaker. It's wonderful research. In Thailand, we we can learn a lot from your presentation. For me, my personal interest is about mental health too. I think it's gonna be quite same situation in Thailand too, even in rural area, because during COVID pandemic, they cannot have stable income and they have to pay for their children. They have to stay at home. Maybe they have to buy more computer for learn online. Yeah, if we have opportunity to join about the mental health intervention, be interesting too.
Thank you very much.
Thank you very much for comments. Okay. So any other comments or questions from?
May I have a comment?
Thank you for
Nakashima Sensei.
Go ahead.
Yeah. Thank you very much for the presenters that already, I think, presents a wonderful work. And I actually would like to see our experience, which is, I think, very, very important that in our case, to introduce the PSC to the health worker as well as to the healthcare is really a challenge. So I think it will be very important also to do the more qualitative study in terms of the training introductions, which is, I think, would be very good informations also how to introduce this PSC concept, especially to those who not really familiar before and also have the lack of digital literacy. Because I think at the very beginning, it seems that we put the health workers on stress that they have to take the data, and of course this is will burden also the quality of the data. But on the other side, the issue of preparing the material to do the training and also to make them familiar with the system is another challenging process, which is, I think, many lessons learned can we get also from this activity. Yeah, thank you.
Okay, thank you. I think I also the training, the process is really important for the health worker. So how do you think, Mark?
Yeah, actually, this is really very important point you have mentioned, because especially in case of PSC, where our main target is to provide the support to the rural community, and our main objective is to use the rural human resources. So if we try to use the unexpert, I would not say they are not the doctor, but maybe they are some sort of health worker. So it's very important to let them understand the system perfectly and how to use the system, because if they cannot perform properly, it will be difficult for the doctor to provide the consultancy from the distance. So I agree with you that we need to give more emphasis on the training module and training things. And actually, Grameen has a total package of training, and they have a 5 days training program, training module, everything covered by this 5-day training regarding the PSC system. So in fact, we can offer the training, online training also. Like recently, we offered the online training to the Thailand team. We offered the training to a Nepal team using the Grameen resources. So that kind of preparation are with us, but I think we can do some activities together. And if needed, we can further improve the training material and training resources. And we can translate the training material. Actually, all the training material are in English, but if you feel that it's important to use it in the local language for the local human resources, that can also be done with joint collaboration. We would be happy to support in that area. Thank you for raising this point.
Thank you very much. So now it's just a time. Thank you very much for your hot discussion. I want to pass to Mark.
Okay, thank you very much. But Nakashima-sensei, if Dr. Norris is here, I would like to hear from you too. Dr. Norris, are you there?
Thank you, Robico.
Yeah,
Bye. As a great presentation for all presenters, then we got some learns from that. And then for Indonesia situation, actually, when we did this one, we are as the presentation from Anai Sensei that we are in the beginning of the COVID-19, and then in that times, the team should be trained by online too. The training together using the online, and then we should do some on-the-job training directly because limitation of the situation, such as like a lockdown. And then we have a good chance to do PhD in the field level. And then actually based on the discussion from explanation from Lutfan, that it is very grateful to have this collaboration. And then we would like to try to scale up the process with more efficient for the PhD, because in that time we know that the question is too long and so on and so on. But this is really make us open our mind that the people in the field level need a process of the this process to the cadres. Actually, as Pak Lutfan mentioned, that this is a part of the program of the insurance, National Insurance Agency, but they don't develop this one, and then we try to develop this to simplify the process and then make easier for the coming Prolanis. Thank you, Pak. Thank you, Sensei.
Yeah, thank you very much. Thank you very much. So I think there are many things we can discuss today, but as we have a time constraint, maybe we will continue our this kind of event in another session next time. But for today, as we have to close it shortly, finally, I would like to invite Dr. Fumihiko Yokota Sensei to give a closing remark for today's session.
Thank you, Maru Sensei. Thank you, everyone. I would like to thank every speakers and all the participants from 7 countries today: Bangladesh, Indonesia, Malaysia, China, Thailand, India, and Japan. We are now, it's called uncertain and very difficult time and very volatility era, such as COVID-19, climate change, and the war. However, we believe PHC, like patient to doctor to patient telemedicine and remote healthcare system become a new normal to solve these social issues and to save people's life. So I really appreciate this opportunity, and I hope we can work together, continue our collaboration for the future. I really look forward to work offline next time. And we cross our finger for the better future. Thank you.
Thank you very much, Professor Yokota. And actually, with this, we would like to conclude this session. But before that, I would like to thank all of you once again for participating to the session. And there are many issues we like to continue our discussion. So hopefully we will have some another event, another session in near future. Until then, as we are passing through the COVID situation, I would request all of you and pray for all of you to stay safe, and hope to see you next time again. So until then, thank you very much.
Let's take a picture. So
can we have a group picture? If everybody's open your camera. May I request all to open your camera so that we can have a group picture. So anybody else with the camera?
There are 59 participants. Can you grab them all in a single window?
That is a negative.
I took picture 3 times from 3 windows.
Thank you, Dr. Ashir.
Okay, thank you. Thank you very much. Okay, we will conclude here. Bye-bye.
Yeah,
Bye-bye.
bye-bye. Have a good day. Yeah, bye.